Okay. Yeah, okay, I can hear her, and I think she can hear me as well. Okay, let me take this out, and I can hear you guys as well. So there's not much more to cover. Today's a hell of a day. So I'm sure you must have heard everything that's happening in the hospital at the moment. Okay, speak to the interns, they'll tell you. But there's like a whole lot of sweeping changes. So I've got to go from here and like start sorting things out. So we didn't have much more to cover. In fact, we're talking just about beta blockers and calcium channel blockers. All right. So generally are antihypertensives. Okay, whatever you can see over here. So the thing is with antihypertensives as well, because they are generally dished out in large packets, you know, people get 50, 60, 30, something at a time. And it's also one of those drugs that's considered, I may not get that sick. So it can be a parasuicide attempt some of the time. But a lot of people understand the implications of taking these drugs. In other words, they know that if they take this, there's a good chance that they will go. But it's not your go-to drug for suicide, for example. All right. The reason being, there's a lot better things if you really want to kill yourself. So if you are a lay person walking on the street, you would look more at sleeping tablets. You know, I'm just using colloquial terms, sleeping tablets. You would look at things that, yeah, you may look at heart tablets as well, but not necessarily high blood pressure or sugar medication, because you don't think that's going to kill you, you know? So that's why I say it can be sometimes associated with parasuicides, okay? And also, of course, accidental ingestion as well, and by children also. Okay, so the thing is, because it's an antihypertensive drug, the thing that you would expect is hypotension, right? So the reason why it's causing its hypertension is because it's causing a beta blockade or it's causing a calcium channel blockade. Okay, so it's relatively easy to understand why it causes that, right? The thing is that hypotension may start many hours after the ingestion. So for example, the patient's taken the drug, it's in their system, everything seems fine. Even when they come to hospital, everything seems okay. And you may be tempted to say, okay, this patient is fine. I'm just going to admit for observation. I'm just going to have a look at them and see what's going to happen. The truth is that while they are sitting and waiting, they are going to deteriorate. So these are the types of patients you've got to start thinking about how much did they take and how am I going to monitor them? So ideally, they should be monitored in a high care area if you have one, cardiac care unit if you're in a big hospital, or in an ICU, or on BP monitoring. In other words, every 5 minutes, somebody needs to be taking their BP and just see what's going on, you know? And that's basically what it is. Just 1 second. Sorry. Okay. What are they saying again?
You have to monitor them.
Oh, yes. You have to monitor them for quite some time until they actually, what you call it, either don't develop the hypotension or develop it and then you can treat it. Okay. So what happens is, and this is actually quite an early problem, they sometimes develop severe tachycardia. That's in response to the hypotension, although the beta blockers generally tend to prevent that, or bradyarrhythmias with the beta blockers, because we know beta blockers cause bradycardia and things like that. The problem is with these patients, they can get sudden cardiac death, specifically with the calcium channel blockers. Okay, not so much with the beta blockers, but with the calcium channel blockers, they can suddenly just go into a fibrillation and die. Okay, so in these patients, my advice is always seek senior assistance. And when I say senior assistance, I don't just mean your medical officer or ComServe officer. I'm actually talking about getting the Department of Internal Medicine involved. They need to get their, consultant involved if available. They need to consult the toxicology centers, things like that, because these patients just suddenly deteriorate. And it's something that even we as doctors, because we're not really trained in toxicology, we may not realize. You know, we may understand that there may be some potential for hypotension and things like that, but it's often something that we also overlook. Okay? So we use something called the JIC protocol, right, or euglycemic protocol to treat these patients. So it's glucose, insulin, potassium, GIK protocol. Okay. So the whole point of this is that you're trying to flush the heart with as much glucose as possible to keep it going, all right? And the way that you do that is by giving the patient a lot of insulin. So that insulin forces glucose into the cardiac muscle and thereby keeping it pumping, regardless of what's happening with the calcium channel or beta blockers and things like that. Now, the thing is, the euglycemic protocols, it's relatively easy if you've done it 1 or 2 times. But if you've never done it, it's actually very confusing. All right. So I've given a basic one here, but the truth be told, it's not a one size fits all kind of thing. So if you can remember this one, that's very good. But my advice would be that if you are faced with one of these patients and you don't have any form of help around you, just remember the euglycemic protocol. You can Google it quickly. Generally, there's a lot of guides, even on Google Images, for example, you'll find the guide just comes up and you can immediately follow it, and you'll save the patient's life, right? But like I say, basically what we're doing is we're trying to give high dose insulin. We're trying to flood the system with insulin so that insulin will force glucose into the system, right? Alternatively, if you have access to glucagon, which is not readily available in most hospitals or is strictly controlled, it also works quite well. And high-dose insulin euglycemic therapy is useful for a lot of things, a heck of a lot of things. To give you an example, if your patient has a bolus stuck in the esophagus, and they just can't swallow it, give them this. It just gets it moving in no time. Same principle. It just flushes the body with glucose. Suddenly that esophagus got a lot of power, moves it down. All right, so there's a lot of things that it's useful for. So it's a nice thing to go and read about. The basic premise behind it is that you give 1 unit per kilo of act-rapid insulin, all right, a rapid-acting insulin given as a bolus, all right. So what's going to happen if you give a large amount of insulin as a bolus? Your glucose is going to drop. So you have to supplement them with glucose. I generally would say 40 to 50 moles, 50% glucose. And of course, your potassium is going to drop with this. So you also have to start them on potassium replacement. Remember, you never bolus potassium. Okay, just remember. Okay, bolusing of potassium is also known as lethal injection. Okay, it's known as a lethal injection. Okay, that's how they kill people in Texas with potassium bolus. Okay, so we never bolus potassium. Just remember that for the rest of your life. Okay, we give it very slowly. We give it over a long period of time. Even though potassium drops, once you start replacing it, your body actually handles it quite well, right? And the thing is, whenever you're giving this type of euglycemic therapy, we always do blood gases before and after because we have to keep on checking parameters and know what's going on, right? So this type of euglycemic therapy normally carries on in ICUs and things like that. And these patients can take a very long time to get better because the majority of the drugs are slow release. The majority of hypertensive drugs are not meant to act for half an hour. They're meant to act for 12 to 14 hours, and then you take your next dose. So they're meant to act for 20 hours. So when the patients overdose them as well, they tend to, remain in the system for quite some time. So the ideas of removing drugs from your systems, like using sodium bicarbonate, lipophilic therapy. There's a lot of other things that are used by intensivists, but because we don't work, we're not too worried about it. Okay. So if you have a calcium channel blocker, we also add calcium gluconate or chloride, depending on what's available in your area. And it, of course, supplements for the calcium channels because you're blocking those calcium channels. So you want to make as much calcium available for the channels that are available. So you just give them a bit of calcium gluconate or chloride, right? And like I say, what we talked about in the previous slide, which is a euglycemic therapy, if you don't have it available, then glucagon, ideally you want to give glucagon, not what we talked about. But like I say, glucagon is actually very difficult to come by, surprisingly, in most hospitals, and if you do get it, it's a little precious little case, and the pharmacist comes and gives it to you in your hand, and you've got to hold it, and they want to see who you're giving it to, and there's a lot of paperwork involved. The simple reason being it's quite expensive. All right, so most hospitals will just keep like 1 or 2 vials ready, and maybe for ICU. Okay. The one other thing to consider, thanks for everybody who came now. I was just telling you guys, it's a very short presentation today. We're actually just finishing our toxicology. I don't even know if there's another slide after this. I need to check. Because with everything that's happening with you guys, pointing at the 2 of you, there's a lot of paperwork that's going on at the moment. So I'm just trying to get through. So the one thing about these patients is that if they do arrest, so we're talking about calcium channel blockers and beta blocker overdose, okay? if these patients do go into cardiac arrest, these are some of the patients where you do extended CPR. So extended CPR is regarded as 45 minutes. Okay, so the normal is 20 minutes. We normally do CPR for 20 minutes. If there's no response, we call it. There's no use beating a dead horse, if you get what I mean. However, there are some circumstances in which we advocate for extended CPR. Pediatrics, number one, right? Pediatric patients who go into cardiac arrest, very often the problem is not a primary problem of the heart as compared to adults, who die from ischemia and renal failure and things like that. Kiddies tend to die from hypoxia, which eventually leads to cardiac arrest, generally, right? So because the problem is not with their heart, you keep their heart beating until you try and solve the other problem, either through ventilation, a mask, intubation, things like that. And this is another case where you try that. Because what's happened is that this patient has taken a large amount of these drugs that stop the channels from working or that slow the heart down. So if you can try and reverse that a little bit and continue to make the heart beat, there is a possibility that because they don't have a primary cardiac disease, they can start having spontaneous circulation. Okay. The pathophysiology behind it also has to do with the amount of pressure that you can generate in the coronary vessels, the way that you treat the actual, how do I explain, where you actually treat the overdose. So in other words, that you're giving your euglycemic therapy and things like that, which takes a bit of time. It doesn't go in immediately. The way that insulin forces glucose into the cells and things like that. So because of that, we advocate for 45 minutes. Now, you don't need to remember all that other parts that I said, just remember the 45 minutes. Right? So basically, these are some of those patients where after 20 minutes, you don't say, okay, there's nothing, we're calling it. You can be held medico-legally responsible. In other words, if the family comes back and they come with a lawyer, you are responsible because this is one of those cases where it's expected that you will go for 45 minutes. Right? Like in a kid as well, that a kid that drowned, and you're there at the, you're trying. If you just stop after 15 minutes, they can ask you, why did you stop? This is a child, why did you stop after such a short time? It's very different, like a child who's got a massive head injury or, severe open wounds. That's different. This we're just talking about cardiac arrest. But it's it's an ethical topic as well. But what I can tell you is this is one of the few where it also becomes a medical legal aspect, okay? Where they can ask you, why did you not do extended CPR for a patient with such a problem, So you have to now explain your training, where did you study, how many of these patients have you seen, how experienced you are. It's a whole lot of hassle. So rather spend the extra 25 minutes doing CPR instead of spending months in court and writing statements upon statements upon statements. All right, so this is a nice little diagram that I actually need to put up in E&E at some point. So it's the entire approach to a poison patient, okay? So basically, what are you looking for in the eyes, the lungs, the heart rate, the skin, bowel sounds, blood pressure, temperature, simple stuff, all right? But basically, the combination of most of these things. So for example, a hypertensive, hyperthermic, myotic, tachypnic, tachycardic, red patient with absent bowel sounds is a tricyclic antidepressant. Don't worry if you don't remember that. I'm just giving you an example, okay? Myotic, cold, bradycardic, bradypneic, hypotensive patient with hyperactive bowel sounds and wet skin is an organophosphate poisoning, just as an example, okay? So it's just a nice thing to know, what you need to look at. But these are basically, 1, 2, 3, 4, 5, 6, 7 parameters that you can use. Now, if you're feeling lost, go back and watch the previous videos where we covered each of these things, all right? But it actually covers all of this stuff over here, okay? So as I say, toxicology, it's not an easy subject. It's actually quite a difficult subject. That's why we have the whole poison center and things like that to assist you, all right? So if ever you're stuck or if ever you're lost, you always contact the poison center because those people are specialists. They know exactly what to do in each situation and they will guide you along, all right? So there's a few ways you can get hold of them online if you have AfriTox available, which I'm hoping to have on the computer by next week, or you contact them. telephonically, and they will guide you through step by step, and they'll tell you exactly what to do. Okay, so that's the most important thing to do. But in summary, remember your basics. Always cover your ABCs. Okay, sorry, let me just get that up. Always cover your ABCs. Remember to stabilize your patient before you do anything else. Look at everything: the eyes, the mouth, the skin. Touch the patient. What's the pulse? What's the temperature? Are they sweating or dry? Do your testing. Blood glucose, blood gas, baseline bloods, ECG is extremely important. Try and classify the patient. Okay, it's something that you guys do all the time, even though you don't realize it. As soon as an organophosphate walks in, each of you knows how to classify an organophosphate. Am I right? If you see a patient who's not in their right mind with pinpoint pupils, even before you look at anything else, what do you say? Organophosphates, agreed. You're already classifying these patients. It's just to broaden your knowledge that you can classify different types of patients. Okay, and then you try and treat the patient. When we say treat the patient, what we mean is provide the antidote, because the only thing that will help your overdose patient is to counteract the chemical that they've taken in. Okay, so by doing that, you can actually save a lot of patients if you end up doing emergency department work over a long period of time, which I pray you don't. It's a horrible place to work. But if you do, you've only been here for 1 week. Come on. Okay. So I don't know if there's any questions, or if there's anything that you guys would like to. That's just a joke to finish off. We covered this, so we've been covering this topic over about 6 weeks. All right, this is going to be our 6th recording now that we put out. And as I told you last week, we just touched the surface of toxicology. We didn't even scratch it. We just touched the surface of it. It's such a broad topic. There's so much. But if you can understand basic principles and you can know at least how to try and approach the patient, it makes life a lot easier for the simple reason that there are common toxins and there are uncommon toxins. So for example, organophosphates, very common. Cocaine overdose, you're going to see maybe once a year. Do you get what I mean? But if you know how to manage an organophosphate and a tricyclic, what will happen is when the cocaine overdose or the beta blocker overdose comes in, at least you look at the same things. I'll remember to look at the eyes. I'll remember to look at the mucous membranes. I'll remember to do the ECG. I'll remember to check the skin, things like that, you know? So you use the same system regardless of what poison is taken, and it can help you to classify that patient. Once you can classify that patient, then you've got an idea of what you're dealing with. Then you can search up and try and get help on what's going on. Because the biggest problem is that very often we don't even know what our patients have taken when they come. Okay, so that's where the difficulty comes. It's very easy when they come in and say, I've taken this, you know, you can even Google what to treat it with. You don't even have to phone the tox center nowadays, right? But that's the approach to it, okay? So what we're gonna do from next week is we're gonna do toxinology, right, for a few weeks. Any idea what's toxinology? No idea. What do you think it is? Sorry?
Something with medication.
Something with medication. Okay. Snake bites, scorpion stings, spider bites. Okay, that's toxinology, the study of those things. All right. So we're going to cover that over about maybe a week or two. Okay, just so that you guys have an idea of how to manage that. And then we'll get back to other topics. Okay. So any questions specifically about today? Anything you guys were worried about?
When you use glucagon, you also have to give the glucose.
Surprisingly, you don't. Glucagon is, that's why it's such a lovely thing, but also why it's so expensive. It's just simply one dose given IM, not even IV, just into the buttock. And then glucagon goes in and does everything that glucose, insulin, and potassium would do without even dropping your potassiums. Basically, what it allows for very quick glycolysis, gluconeogenesis. Something else that it does as well. I was just going to check it up just to refresh my memory as well. But it's like a wonder drug, you know, for all of these things. So even patients who have got refractory hypoglycemia, things like that, glucagon is your go-to drug. And its uses are quite extensive. If you have a chance, go and check up on it. You know, it's actually quite an interesting drug to look at. So it's not something you get hold of very often. And like I say, it's normally strictly controlled. It's under consultant directive, things like that. But if you can get hold of it, great. And if you can't get hold of it, then you use the euglycemic protocol. And it just does the same job, just that you have to monitor the patient more closely. That's about it. Okay. All right. No problem. So we'll call it there. Just so that I can sort out